And now it's my privilege to invite Dr. Devesh Kumawat, who's Assistant Professor in Vitreoretina Services at the API Center of AIMS, for his talk on managing vitreoretinal incarceration in open globe injuries.
Thank you, Dr. Simha. So so when we are dealing with patients with vitreoretinal incarceration in open globe injuries, it's not moving forward. Okay, so when we are managing patients with vitreoretinal incarceration in open globe injuries, we often face these dilemmas whether we need to intervene in such patients. First, any intervention is required or not. Second, whether to intervene early or delay it so that the ocular tissues, they come to a natural state and allow you a safer surgery. And if you have planned to intervene in these patients, then do you need external support in such cases? And how do you manage the retinal incarceration that occurs in these cases? So I'll take you forward with a few cases. A 41-year-old male patient who had road traffic accident and a scleral rupture and an orbital floor fracture, which was repaired on the same day. And he came to us at day 7 after trauma with vitreous hemorrhage, and on ultrasonography there was an inferior RD along with the vitreous hemorrhage, and the patient was taken for vitreoretinal surgery at 2 weeks after the trauma. So we took the patient for 25 gauge vitrectomy and give a peribulbar block. And here, after clearing the vitreous hemorrhage, we noted that there was an inferior detachment involving the macular area, and there was an incarceration site in the mid periphery. We cleared the vitreous hemorrhage all around the incarceration site, taking care not to create any inadvertent retinal breaks. And now we are debulking the vitreous which is there overlying the incarceration site. PVD is being induced using triamcinolone, and then it is extended all around the incarceration site. And then vitreous is removed all around the incarceration site. Once it is free of any vitreous, then it is, now we are using the diathermy itself to do a retinectomy. We are using diathermy at 40 power rather than normally we use at 16 or 18, and now we are using diathermy at 40, which is vaporizing the tissue. So this creates minimum removal of the tissue, and we can achieve a very small area of retinotomy that is to be done. And then laser is done, and then silicone oil endotamponade is done. Silicone oil is used for endotamponade. So this is a 2 weeks follow-up. The retina is well attached. The retinotomy can be seen all around the incarceration site. And at 2 months, the BCVA of this patient was 618 parts. However, you can note that a lot of retinal fibrosis has still happened, which will happen in these cases irrespective of whether you are doing a complete retinectomy around the incarceration site. If we would not have done the retinectomy in this patient, then the fibrosis would have been much more and would have led to redetachment. Now, case 2 is a 22-year-old male patient with hammer chisel injury, and at day 3, the patient had repair of the lid laceration and inferior corneoscleral laceration, which was involving zone 2 and zone 3, zone 1 and zone 2. The patient had vitreous hemorrhage and the vision was finger counting close to face. We did the ultrasound. There was focal area of vitreous incarceration just close to the disc. And on CT, there was an orbital foreign body which was not impinging on the important structures, and it was decided to leave the foreign body in the orbital cavity and not intervene for that. But we took the patient for vitrectomy for clearing the vitreous hemorrhage and for managing the vitreous incarceration. So here, after clearing, after performing the core vitrectomy, we are doing the PVD induction. We are inducing the PVD initially in the superior part away from the incarceration side, and we are debulking the vitreous as much as possible. Now we go to the incarceration site and move all around it, 360 degree around it, so as to free any vitreous from the, any connection from the vitreous base area. So now once it is freed, then we complete the anterior vitrectomy, and then come to the incarceration site. It is traversing through the inferotemporal arcade and causing some edema of the macular area. So now we are using diathermy at 16 power, and to highlight this area where we have to cauterize further and dithermize further and create a chorioretinectomy. So 1 mm chorioretinectomy is done using the diathermy itself at very high powers, so the tissue vaporizes and it gives you a beautiful and sharp edges of the chorioretinectomy that can be achieved. And after doing an alum peeling, we have done laser around the exit site, and then silicone oil is being poured. So at 1 week follow-up, the vision was finger counting at 2 meters. There is some ischemia which is there in the inferior part of the macula because the arcades have been affected. And but on OCT we see that the retina is well attached. At 1 month follow-up, the BCVA was 648. There was some atrophy involving the inferior part of the macula. And at 3 months, the patient retained a visual acuity of 660. But however, if you see, there's a focal area of traction which is developing between the incarceration, between the exit site and the optic disc. Now, case 3 is a 27-year-old male patient who had penetration injury in, while working in a factory, and he had zone 2 and zone 3 scleral laceration, and which was repaired. And then the patient presented to us with vitreous hemorrhage, retinal detachment, and retinal incarceration. And vitreoretinal surgery could be done only at 3 weeks after the injury when the patient presented to us. So you can see the scleral wound which has been repaired involving the zone 2 and extending zone 3. So we placed our sclerotomies slightly away from the wound so that we can approach this area of incarceration. As the retina is all dragged up into the wound, the vitreous is going into the wound. So after doing core vitrectomy, we use our tricot and induce the PVD and extend it all around. So then we approach the area of incarceration. We remove all the vitreous that could be safely removed. And after removing as much as vitreous as possible, we diathermize again. We are using the diathermy here. And using the diathermy itself, here again we are vaporizing the tissue, and the residual tags which remain, then you can cut them with the help of the cutter. This is followed by retinotomy on the nasal side and fluid air exchange. And the retina flattens, and then you laser all around. And you can do cryotherapy also to the anterior edges if it is not possible or if the patient is faking. Now this is at 2 weeks follow-up. The retina is well attached, but you see here that because there was a delay in the surgery, a larger part of retina had contracted, and you end up doing a larger retinectomy in such patients. Now case 4 is a perforating injury, and now here there are separate zone 2 and zone 3 wounds which are there. So there is an entry wound which is there close to the limbus, and then there is an exit wound which is posterior to the equator or just at the posterior to the equator. So in such cases we can put an encircling element. Rather, unlike the other cases which I had shown, the scleral wound was passing through the zone 2 and zone 3. So we could not place an encircling element or a buccal element in those patients easily. But here dissection is easy, and we can place an encircling element. So we have passed an encircling element to provide support to the vitreous base, and this is the area of incarceration. We are removing as much as pre-retinal fibrous tissue as much as possible, but it is always not possible if there is a long delay. And then we are diathermizing, and then using the cutter now this time to create the retinotomy around the incarceration site. And here scissors are used to cut the fibrous tissue between the entry and exit wound. And you diathermize and achieve a hemostasis, and then do a fluid air exchange. And then you tie the final tie to achieve a good indent. And here we are doing cryotherapy, and posteriorly we have done laser of the retinotomy site. Now the key aspects in management, first is you assess the need for surgery. Majority of the times you will end up doing vitreoretinal surgery. Now the importance is that you perform an early vitrectomy in such cases. Don't wait for the things to settle down. Maybe a week time is more than enough for the wound integrity to come in, and you can safely do a vitrectomy. Maybe keep the pressures lower down and not too high so that there is no wound leak during the surgery. Preoperative planning can be is of utmost importance. You can perform an ultrasonography and a CT to localize your entry and exit wounds and plan the surgery accordingly. Wherever is possible, use an encircling element if it is not involving the area where, as we saw in the last case, where the entry wounds and the exit wounds were too far apart, and we could easily place an encircling element. Plan your sclerotomy incisions wisely away from the entry and exit wounds. Then PVD induction is of utmost importance, and also is the shave vitrectomy in the area of incarceration. And then you have to release the retina completely. If you do not release the retina completely, the retina may settle intraoperatively, but later on retinal fibrosis do happen, and that will lead to redetachments. And then silicone endotamponade is important because there are high risk of proliferative vitreoretinopathy and redetachments. Thank you.
Thank you, Dr. Devesh, for beautiful surgical videos. So I have two questions. One is, do you use silicone tamponade in retinal incarceration without retinal detachment also?
So if there is no retinal detachment, then it will depend on case-to-case basis if it is inferior. So in the first patient, we were able to clear majority of the tissue around the incarceration site, and I initially thought that let's put even C3F8 gas could be put. But then I ended up putting oil only because we should err on the safer side. You saw in the post-op period, despite putting oil, there was retinal fibrosis, and in the second case also a linear tractional fold started developing between the wound and the disc. So you end up having a lot of PVR in these cases, so it is important that you put silicone oil.
And do you recommend putting an encircling band, especially in anterior vitreous incarceration patients?
So again, if it is a superior entry wound, then I may not put it also, but if there is inferior 8 clocker involvement, then I would generally put an encircling element, as well as a buccal if it allows a placement, easy placement without much dissection.
Thank you.
Fantastic presentation, Dr. Devesh. I just would like to add on one thing that coming to the encircling band, my usual practice is I go for an encircling band in whatever doubtful cases I feel, even if there is no obvious detachment on the ultrasound. But if the ultrasound looks pretty bad, where there are a lot of vitreous adhesions and tractions, my entire rationale behind this is you may have a large break, probably an inferior break, which has yet not caused an RD, but after the PPV, even after putting an oil, just as you showed in the case, you may end up having a redetachment, so it's always better to have a support. My question is, do you have, what's your take on the use of 360 prophylactic laser barrage? Do you do it in your cases?
I normally do not do it, and only if the media is not very good and you are not sure, then I may end up doing a 360 laser, but normally if the media permits, I do not normally do it.